Hello, and welcome to this Learn session. We're going to discuss Chapter 14, Communicating and Therapeutic Relationships, and Chapter 15, Patient Education. Let's start by Chapter 14, Communicating and Therapeutic Relationships. So, what is communication? It's a dynamic reciprocal process of sending and receiving messages using words, sounds, expressions, body movements, written symbols, and behaviors. Communication forms the basis for sharing thoughts and emotions, expressing needs, and building effective working relationships among individuals, families, and the healthcare team. Communication is basic. It is a human need that we all have. It is a very essential tool for interaction, both bidirectional exchange of thoughts or feelings, and a way to meet physical, psychosocial, emotional, and spiritual needs. It is indeed a process, acting of sending, receiving, interpreting, and responding to a message, and it involves content, the actual subject matter, words, gestures, and substance of the message. There are different levels of communication. Interpersonal, which is that self-talk, inner voice. It can be positive or negative. And I happen to think this is a very important one because how we talk to ourselves a lot of times overcomes any outside sources, like interpersonal, which is between two or more people. Groups, many people at the same time communicating together, or public speaking is a unique form of group communication as well. So one of the things to think about is interpersonal is really the conscious internal dialogue. Interpersonal is really that face-to-face conversation. And then group settings is amongst several people at one time. So what are the components of communication? One essential component is the content itself. It really describes the actual subject matter, the words or gestures being exchanged. And this is essential to the message that everyone may hear or see. So it does involve encoding, decoding, message receiver feedback, and all of those intra and interpersonal factors between a sender and receiver. When we look at the components of communication in that process, the sender delivers the message to another person, the receiver interprets the message, and then encoding happens. So that is the process of selecting the words, gestures, your tone of voice, the signs and symbols that are being used to transmit the message. And the message itself is the actual word being said, the gesture being displayed, or the letter that is being displayed or established there. One of the things I want you guys to know is if you saw a scenario about a sender, a receiver, and an encoding message, are you able to tell what encoding actually is? Let's practice. During the communication process, encoding is A, the selection of words by the sender, B, the interpretation of the message by the receiver, C, the message by which the message is given, or D, the way in which the message is interpreted. Take a couple of seconds and make your selection. The correct answer is C, the method by which the message is given. Verbal communication and impactful factors. When we look at vocabulary, it is your responsibility to deliver messages that the client can understand. Use medical terms only when you are certain the listener understands them. When encoding a message, consider the receiver's age, their knowledge, education, and any cultural differences, including primary language spoken. Encourage feedback to be sure that the receiver understood the receiving message. And denotative and connotative meaning. Denotative is the literal or dictionary meaning of a word, and in contrast, the connotative is the implied or emotional meaning of the word. Pacing of conversations, the pace and rhythm of delivery can alter the receiver's interpretation of the message. So be mindful of how fast or slow you are talking. And then intonation, also known as the tone of voice, reflects the feeling behind the words. We get a sense of a person's kind of tone of voice and their mood by listening to pitch, high pitch or low pitch, or the cadence rising and falling of the pitch, and volume soft or loud. For example, if I am calling you from across the room and I say, could you please come here? Versus, could you please come here for a second? Or if I said that right there versus that right there. Those are connotative of different moods, different cadence, different flow, and can elicit different emotions. So be cognitive of that. Clarity and brevity. Clarity is using words that convey your intended meaning and matching your verbal and nonverbal language. So if you are exhibiting some behaviors that show frustration, rolling up the eyes, sitting down your book harshly, or pulling out your chair in a certain way that establishes I'm hot and bothered right now, versus if you are gentle and smiling and rather slowful with your behavior and not so rash and brash, then that communicates different emotions and can elicit different response. Things like timing, relevance of the information, credibility of you, the sender of the message, and the utilization of humor can all be tactics for different communication with your patients. So let's take a look at this. The nurse is teaching the client about their upcoming procedure, and the client is very stressed. What is most important for the nurse to do? A, use humor first to decrease the client's stress level. B, determine if the teaching should take place at a different time. C, introduce yourself as the RN to give credibility to your message. Or D, speak to the client when family members are there so they can teach the client. Take a couple of minutes and then we'll revisit the answer. The correct answer is B. Clients who are stressed may be unable to listen fully and will not receive or understand the intended message. And so you, as the nurse, will need to decide if there's a different time and place to deliver that education. So nonverbal communication, a lot of times we will receive different nonverbal cues from the patient, and that will help us to determine our next steps in care. Some of the factors that impact nonverbal communication are things such as facial expressions. These can communicate joy, anger, sadness, concern, or fear. For example, raised eyebrows, staring, squinting, or darting eyes all convey different meanings. The interpretation of facial expressions is culturally dependent as well. So we do want to be mindful that sometimes the nonverbal cues we're used to doesn't mean the same thing in another culture. Posture and gait, body position. We talked about this in class, how your stance and your arms and your hands and your face and just the way you're positioned with a patient or client or another individual, it really does display a lot of nonverbal emotions and feelings. And then personal appearance, clothing and personal appearance provide clues to a person's feelings, social economic status, culture, and religion. So dress and accessories are powerful cultural cues, although they are not always accurate. So be mindful that a lot of the nonverbals you may want to make sure you have validation and confirmation by some verbal communication as well. Gestures, hand and body gestures emphasize and clarify the spoken word. They are good indicators of the feeling and tone behind a conversation. Also, distance, your distance between a person when you're talking to them. Touch, the use of touch can convey caring and concern and also can be misinterpreted. So, all these things you have to render with caution. So, what nonverbal cues does this nurse that you see here convey? We see the nurse leaning in, we see light touch, we see that the nurse is facing the patient, we see that there is a slight smile or grin, there's eye contact. And so we have all of these nonverbal cues to say, hey, I'm here and I'm listening and I am attentive to you at this time. What nonverbal communications do we have here? We have the nurse leaning in, we have soft touch again, we have eye contact, the smile. We have this nurse getting down to the eye level of the patient by bending the knees. We have the patient and the nurse facing each other. And so we have a lot of nonverbal that says, hey, I'm engaged in our conversation at this moment. And then general communication considerations. Please do consider the environment. Communication is most successful in an environment that is quiet, private, free of unpleasant smells, and at a comfortable temperature. So just know when you come to class and there's no air conditioner, how uncomfortable that makes you and how distracted you can get from even listening or engaging in the class activities. And then just imagine if we came into class and it was noisy in the hallway the entire time throughout class, that would be rather distracting to your learning as well. So the same thing happens to our patients in the hospital setting. Lifespan variations, things like physical and cognitive development, language barriers, level of education, maturity and influence in the community process. And that just means that we have to consider the age of the patient. We have to consider whether or not they're fully engaged in learning about their care and they are motivated to do so. And then we need to modify our communication strategies based off their lifespan communication needs. And then gender. Every client or family interaction is unique, and there is no one size fits all approach, even with respect to gender. So a lot of times I think when we genderify different things that we really take out some components that could be beneficial for that male or that female that we're going in to assist with education and communication. People have different life experiences, and so that will reflect in their communication needs as well. Some people have a need for their personal space, so make sure that we are accounting for that when we're delivering information. And then a key point, patterns of communication are person specific, not necessarily specific to any one of these categories. You're assessing all these things at once simultaneously and collecting that data that's going to help you better communicate with your patient. Cultural differences and language barriers again came up, role in relationships, and then physical and developmental disabilities, mental illness, cognitive impairment, and then also emotional state or listening skills can also hinder a communication session with your patient. So be mindful that you are assessing all of the parameters, all of the things that are going to have great impact to you displaying your messages to your clients. Style of communication, I want you to review your resources, the documents that I sent via email, so that you can see about the passive aggressive, the aggressive and assertive styles of communication, and remember what we talked about as each group was presenting in class. Communication and collaboration. The team approach here would be a type of situation where we're deciding what is the best item or way to deliver our communication about our patients to the rest of our team. And so FA Davis does talk about SBAR-Q or SBARC. And one of the things that I want you guys to focus on a lot is the SBAR, SBAR, situation, background, assessment, and recommendations. And so one of the ways that this is very helpful is it kind of gives you a basis of what you're looking for and what you want to talk about. So when I talk about situation, background, assessment, and recommendations, it may be the situation is patient is admitted for weakness to the left side and debilitating mobility. Background is post-stroke. A month and a half ago, they were admitted to the acute hospital and did a few weeks of rehab and then went home with home health. Assessment is that patient currently needing assistance to ambulate and feed themselves and has extreme left-sided weakness and some aphasia. Recommendation is that we are asking provider to provide orders and any kind of intervention such as OT, PT, ST for this patient as they're going through rehab now again. And then questions would be any follow-up or anything outside of the SBAR that needs to be addressed. And so during client rounds, you'll hear a lot of the reporting going on, but when you first come to your shift, normally that's when you're going to be giving or getting report. And then therapeutic relationships. This focuses on improving the health of the client, provide the necessary information about health, treatments, and care, and then also involve the use of therapeutic communication when talking to your client or patient. When we think about client rounding, this is really a collaborative approach in which providers and nurses gather at the client's bedside to discuss goals for care and our exchanges in the plan of care and to answer questions for the family, the client, and healthcare staff. Meeting for rounds allows the nurse to provide input, which results in improved nurse and physician working relationships and professional satisfaction. So that's why we want to get to the clinical site early as possible so that you guys can be a part of reporting and that therapeutic relationship building as well as teamwork and collaboration. Phases of the therapeutic relationship, I want you guys to review your emailed resources from the presentation from this last Monday's class, but we are looking at stage 1 through 4. Stage 1 being the pre-interaction phase. I want you guys to know that this is an orientation phase and it involves gathering information about the client, but the nurse and client do not have direct communication as of yet. Stage 2 is the orientation phase. The goal of this phase is to establish rapport and trust using verbal and non-verbal cueing. This stage begins with introduction, followed by an initial exchange of information, such as the client's reason for the visit or chief concerns. Explain step by step what to expect. For example, I will be putting an IV into your forearm, or you will feel a prick, and this IV will allow me to give your medication into your bloodstream to help you get better. Another form of therapeutic communication is when that orientation phase ends and you step into stage 3, which is your working phase. Most of the nurse's time is in the working phase because the nurse communicates care by using active listening. The client expresses thoughts and feelings. There is a mutual respect that is being maintained at this time, and then honest verbal and nonverbal expressions occur. So when we look at this, the nurse is providing a reflective and non-judgmental feedback period for the clients to help them clarify their thoughts, goals, and coping strategies. And then stage 4, termination phase. This concludes the relationship, the therapeutic relationship, whether at the end of the nurse's shift or on the client's discharge from the day. Faculty or services will be able to review and summarize, help to bring the relationship to a comfortable conclusion. Key characteristics of therapeutic communication. We know that empathy, respect, genuineness, and concreteness, as well as confrontation, are pretty much a need for therapeutic communication, and some of them are unavoidable in a way. It just depends on how we address them and carry them out on the floor. And so empathy is the desire to understand and be sensitive to the other one's feelings, beliefs, or situation. Empathy is more about sharing than getting information in. Respect in the therapeutic relationship, you communicate respect by walking the client and valuing the client and being flexible to meet the client's needs. As a nurse, you must be willing to really assess that client's needs while respecting their personal space or their preferences while on the floor. And then genuineness is really how you communicate and situate yourself so that you're in a position to be honest and available to the patient. So tell the patient you need assistance before you can answer the question. Let the patient know that, hey, I am going to address what you just said this way with a little bit more support, but don't just not show up and not be there. So there are ways to address the genuineness and also concreteness. This is something you must offer to understand the response to a client's questions or concerns. To do so, it requires you to express in concrete, specific terms what you mean. So be straight up, be straightforward with the patient in an empathetic, respectful, and genuine way. And then confrontation. We know this is inevitable, but for some reason, a lot of us still have issues confronting things. And so confrontational is a reciprocal process. If your client is unable to express their thoughts clearly, you must be willing to confront them to request clarification. Or similarly, you must be willing to be confronted if they are unclear about something as well. Let's look at some common barriers to therapeutic communication. Your tone of voice matters a lot. We don't want to be condescending, disapproving, or impersonal when we're talking to the patients and trying to engage them in their care. Using medical jargon is sometimes overwhelming, and medical jargon is really technical language or language really specific to our profession. And a lot of times people don't know what words mean, and so it's pretty much like you're speaking a different language, and it can be hard to understand and respond to medical jargon. So we want to use something called layman's terms. That means just regular talk, regular everyday words that are very common and easily understood. And then asking yes or no questions rather than open-ended really doesn't leave you in a very therapeutic space with most individuals that you'll deal with, especially our patients who might not have been asked the right questions to render kind of beefier response is something for the medical team to work with. And then using too many probing questions or failure to ask questions. So if you ask too many questions, it can be overwhelming and shut them down. If you don't ask enough questions, you might not gather your data and they might shut down anyway from boredom. And then overly dominating the conversation, interjecting yourself a whole lot in the conversation where your patient can't even get a word in. This does indeed, create a barrier to therapeutic communication. And then personal biases, feelings, and insecurities, even your own insecurities. As you guys are going out into the clinical space, your confidence is going to be very important. Your ability to be assertive, your ability to go in at the bedside and feel like you can have a conversation with your patient is either going to make or break that communicative relationship while you're there, and either render some things that are great for your care plan or hold you back from digging deeper into some interventions that will really matter for your patient. And then language and cultural differences. Again, this is going to continue to come up as you guys get out there and start to meet more clients and patients, getting to know that area and all the things that are important to this culture with healthcare. And then also not enough time. You guys know that we run out of time all the time. You run out of time talking to your family members or your friends. You run out of time trying to get your work accomplished. You run out of time in class when there's more to talk about. You're also going to run out of time when you're building therapeutic communications with your patients. They might have to go to the cafeteria for their meal or an activity on the floor or be tired and sleeping, and just not enough time for you guys to sit down. And then plus you're on a time schedule when you are working in the clinical space. And so these things have to be considered as well. Group communication, what types of groups are there? So task groups. These are formed to address a task or fulfill a specific need. Typically, members are chosen based on ability to complete the task. Other times, members are selected for reasons of convenience, such as availability, interest, or agenda, rather than the skills needed to accomplish the goal in mind. So one of the things that you guys recently were offered is to select groups to communicate about your upcoming test. And so one of the things that you probably thought about, or maybe you didn't, is who is in your group. Making sure that who's in your group are selected strategically to fulfill the purpose of making 100% on your exam, right? And so it was selected by interest, it was selected by availability, maybe even knowledge retention or the level of knowledge of that particular group member. And so you guys had to be strategic, or hopefully you were strategic in picking your test groups for this coming test. And then ongoing groups address recurrent issues. Things like committees are formed for ongoing tasks. Maybe there is a safety group at the facilities that we're at or the hospital that they're focused on maybe hand washing to eliminate infections on the floor for the members, and maybe they have a task group of 7 individuals that are going around and ensuring that proper policy and procedure is being followed. And then self-help groups. One of the things about self-help groups, normally they're voluntary organizations composed of individuals with a common need. So members are encouraged to share experiences and seek support from other members of the group. I remember a self-help group in the maternal infant floor or unit for new breastfeeding mothers. And so they all came together and talked about their experiences and kind of helped each other through that initial phase of breastfeeding. And then therapy groups are organized to help individual members cope with challenging personal issues or stressful life events such as divorce, death of a spouse, or a new motherhood type of counseling. So, therapy groups may also address ways to improve relationships and communication, self awareness, growth, things like that. So, kind of therapeutic and developmental in nature, and these groups can be large or small. I know there is an AA group that has some therapy involved in that group. Also, some self-help, because that is a voluntary program for most that stay in it ongoing. And so you can have a mixture of different groups out in the community and at the healthcare facilities that you guys will be working with. And then work-related social support groups help members of the profession cope with stress associated with their work. I will tell you, during COVID, they had quite a bit of social support groups for those nurses that were working on the acute care floors during COVID, and it really helped them through a lot of the things they were experiencing. So let's look at the nursing process. We have assessment, diagnosis, planning, implementation or intervention, and evaluation. When we look at assessment, things like medications, language barriers, vocabulary, literacy levels, the cognitive state of the patient, their hearing and vision, or aphasia, which is the ability to speak or the inability to speak clearly, and then the physiological barriers and communication style. So let's say we have a patient that is post-stroke that has aphasia. Let's make a diagnosis statement. Maybe it's something like impaired communication as related to aphasia, as evidenced by inability to speak clearly upon assessment. And maybe that is all because they did have that stroke and now they're in the skilled nursing facility for rehab. Maybe they're getting PT, OT, and ST. And so part of the planning and the implementation is individualized based on the problems that you identify with that particular client. And implementation should enhance therapeutic communication and decrease barriers to communication as well. Use of the statements "tell me more about" or "I see" encourages clients to continue talking and expressing themselves. This is called A, summarizing, B, open-ended questions, C, focusing, or D, exploring issues. Take a couple more seconds and make your selection. The correct answer is D. Use of the statements "tell me more" or "I see" encourages clients to continue talking and expressing themselves and is called exploring options. So what happens when we are communicating and our patient or client has impaired cognition or reduced levels of consciousness? What are you guys going to do? Well, you're always going to try to communicate with the patient. There's a lot of verbal and nonverbal ways to communicate. So we are going to try our best to communicate with the patient initially. Do not use the in-room intercom to speak with the client. So if your facilities have a call light system where you can talk back and forth to the client, then you don't want to do that with somebody who has impaired cognitive levels or levels of consciousness that are reduced. You don't want to rush the client. You want to reduce environmental distractions, things like the TV, turn it down, things like get the sunlight out of their eyes or pull the curtain for privacy, things like that that might distract the patient from openly talking to you. Approach the client directly, so you want to be sitting with the patient, talk first and touch second. You don't want to just go in and sit and start touching on the patient. You want to make sure that you're building a rapport first. Do not argue or insist the client agree with you. We are culturally sensitive. We are nurses that understand individualized care, and so we don't go into situations forcing a patient to see and do things our way. We're there to help them in their own healthcare journey. Use multiple communication modalities. So not just talking, and you might add paper. Maybe the patient can benefit from a handout, or maybe the patient can go through like a little prep quiz on their medication, a light one, not like in school, but maybe test them on their medication adherence and start asking them about why you're taking your medication. Provide reminders for them and orient the client to what you're doing and why. Stimulate their memory, as we just talked about. Test their knowledge, and in a gentle way, in a non-condescending way, in a I want to help you way. Use short, simple sentences. Avoid the elderly speak, which is where people feel like you're elderly, so I need to talk to you like this, which can be very condescending, and it can unmotivate that particular individual to listen to you and or engage with you, because you're treating them a less than or lower than a lot of times they think. But elders can hear and they can see, so you can get to know them and treat them individually based off the responses and assessments that you are gathering. And then ask yes or no questions. One of the things that is a little bit more helpful for impaired cognition is for them not to have to explain themselves too much, but more direct questioning, limiting choices, because that can be overwhelming to a person who has an impaired cognitive state, and be concrete, specific. Again, avoid slang and jargon. Use gestures, your hand gestures, your face, your body posture, and don't assume. Always treat everyone. So the next three slides are rather special. We're going to talk about safe, effective nursing care, which is really the basis for what we're offering to each and every client that we are going to oversee. If you answer these questions, the next few questions, and write it down, at least one page worth, either typed or written, and turn this in, I will count 5 extra points on your next assignment. And so I do suggest that you listen, write down your responses, and turn this in on Monday. So, the nurse is caring for a client with dementia who is agitated and having trouble reasoning. How might you, the nurse, show caring when providing a morning bath for this patient? Give some examples. Next, for credit, is Socratic reasoning. So let's look at this. Your client with addiction to prescription pain relievers is aggressively insisting that they need a higher dose than prescribed. Establishing a therapeutic relationship with this client could be challenging. What do you think could cause this to happen? What kind of client factors are you considering with this patient? And what kind of nurse factors are you considering with yourself? And then what kind of family factors, now that we've talked about involving the family and those full holistic care that we want to give to the patient, what are you considering here? And then lastly, what challenges might the nurse experience in establishing client boundaries with this patient with addiction to pain relievers who is currently being aggressive? What kind of client boundaries within a therapeutic relationship are you looking to establish, and what might be the challenges there? Give an example of how the client might be experiencing this situation. So try to have some empathy and compassion and see it from their point of view. And then describe your own experience in establishing a therapeutic relationship that worked or didn't work for you. So tell me about your own experience with this when there's challenges to creating a therapeutic communicative relationship. Next, we're going to talk about Chapter 15, Patient Education. So why is client education important? It empowers clients to take control of their own health care. One of the things I've experienced in community health, home health, rehab nursing, and case management in my career is that the more empowered clients feel, the more they're able to control some of their outcomes that are indeed dependent on the way that they're eating and exercising and existing in the world. And so I have had clients that were on 15 or 16 medications go down to 7 or 8 medications just by them feeling empowered enough to make the changes at home that will lead to better health outcomes. It does improve compliance and prescribed health care. So when a patient gets a medication that is prescribed for them and they go pick it up, are they taking that as they should? And why is education so important to that compliance factor? And then reducing health complications and hospital readmissions. This is a huge thing with case management and acute care in the hospital. Patients being frequent flyers, which means they come in over and over again for the same complications. One of the things that has been researched in the past is how client education reduces complications over time and in turn reduces their readmission into the hospital because now they're compliant and taking control of their own health. And then improving client satisfaction. When you feel more in control, you feel a little bit happier. When you're getting better outcomes because of decisions you make, it does increase your satisfaction about you and your healthcare. And then increasing nursing role satisfaction. There is a thing where we have non-compliant clients, and then there's another thing where we have compliant clients, but they still struggle. They struggle on that continuum of care. And so even for the nurse and just thinking about the satisfaction that comes out of teaching a client a new way to do the same thing or teaching them how to better care for themselves and seeing that they do indeed get better over time is very rewarding. So the 5 rights of teaching: right time, right context, right goal, right content, and right method. So you want to think about the right time. Is your client ready? Are they free of pain? Do they have anxiety? Are they motivated? Has your client developed a trusting relationship to you where they trust what you say? And have you set aside sufficient time for the teaching session and let them know that they're going to have a teaching session? And then right context. Is the environment quiet, free of distractions, and private? Is the environment soothing or stimulating, depending on the desired effect? So you got to make the ambiance, set the stage for your teaching session. And then right goal. Is the client actively involved in planning the learning objectives? Are you and your client both committed to reaching the mutual set goals and learning what that means to achieve that and having the desire for that behavioral change? Is the family or friend included in the planning so that they can help follow through on some of those rather difficult behavior changes, especially if the patient's been behaving that way for a while? And then are there any learning objectives that are realistic and valued by the client? Do they reflect the client's lifestyle? So we want to make sure that the context is right, that the goal is right. So when we're looking about the client situation and we see that they have certain needs, will this new information reinforce some of the information that has already been provided to them? Is the context presented at the client's level? And does the context relate to the life experience and where the patient is in their healthcare journey at this time? And then method. What kind of teaching strategies do you need to use to fit your patient's learning style? Have you even investigated the patient's learning style? And then are the teaching strategies varied? You need a mixture of teaching styles so that you can say the same thing different ways, and hopefully one of those ways will catch. I want you guys to know the 3 domains of learning. I want you to look at your resources from the presentations that we did in class. And so know about your social learning theory, okay? Know about the self-advocacy and the behavioral learning theory, the cognitive learning theory, and also the humanism learning theory. And then I want you guys to know about the different skill sets that are involved in different learning methods like factual, conceptual, procedural, and metacognitive learning. And then I want you guys to make sure that you are able to identify the 3 domains of learning if you were to see them in a scenario-based question. And then factors that affect client learning. Motivation. If you're not motivated to study, can anybody convince you to study or do it for you? No. Even if we give you study tactics, but you are not motivated to sit and use them, then guess what? The learning and the application, there will be a gap there. So readiness is very important. Physical conditioning and emotions set to actually accomplish the goal that has been agreed upon. Again, we talked about timing, active involvement, not just from the patient, but any kind of caregiver support. Repetition. You guys know just by sitting in class and looking at how much information can be sat before you at one time, if you hear things over and over again in different ways, it seems to catch over time. The same thing with your client or your patient. The more you say something, the more you do it in different ways, the more you're setting that learning environment for them to actually receive the information. And then scheduling the session again, and then the amount and complexity of the content. So make sure it's a small amount. Make sure that you have many learning sessions, because a lot of times patients will get overwhelmed if the session's too long, too complex, and too many things to remember. Communication styles will help you better engage with the patient. Special populations. When we look at special populations, we want to make sure that based upon your assessment, you are taking into consideration what that individual will need and adapt what you're doing to what that client's condition is, okay? And then developmental stage, again, we want to stage ourselves with Erikson's, make sure that we know what stage they're in so we can know what kind of things will speak to that particular age group the best. And then cultural factors and health literacy. Again, a lot of times we do give health information on an 8th grade level. I know some facilities even do it on a 6th grade level, so it really depends on the facility. So let's look at this. Nurses must possess the knowledge and skills needed for client teaching so that A, they can complete the documentation forms related to client teaching accurately. B, they can help the hospital meet the Joint Commission standards requiring client teaching. C, they can promote the health, safety, and rights of clients through education. Or D, they can meet the client's rights delineated in the client care partnership. Take a couple of seconds and make your selection. The correct answer is C. The ANA Code of Ethics for Nurses with interpretive statements from The 2015 edition holds that nurses are responsible for promoting and protecting health, safety, and rights of clients. So client teaching is essential in fulfilling that responsibility. Next, the client needs to be taught how to find and check their own radial pulse. The nurse will complete this teaching A, only if the client asks the nurse to do so to avoid causing stress. B, when the client recognizes the need to learn the skill. C, before pain medication is administered when the client is alert. Or D, right after the client is discharged so that they can remember the skill. Take a couple of seconds and make your selection. The correct answer is B. The client will be most motivated to learn when they recognize why this skill is important to the success of their overall treatment plan. So, medication effectiveness. One of the things that happens with you guys as well as student nurses is that once you identify why it's so important to learn a certain nursing skill because someone's life can depend on it, then you're more motivated to learn that particular skill. So let's look at this. Safe, effective nursing care. Suppose you are the nurse planning discharge. You're teaching to a frail, elderly man who suffered a stroke. He will be cared for at home by his daughter. What is the best approach for planning discharge teaching? And how might you, the nurse, show caring for this client? I do want you to consider this as extra credit as well. So add this to your paper. Fill this out and turn this in if you want, again, to have your 5 points added to your next exam. Now, when we look at the nursing process, assessment, diagnosis, and planning for teaching, again, you have to assess all of the needs of the patient, their knowledge level, physical readiness, emotional readiness, ability to learn, their neurosensory factors, learning styles, and more. Most of the time in this area, there will be a deficit of knowledge or knowledge deficit. And for instance, with the patient that needed to check their pulse prior to medication administration, it could be a diagnosis statement such as knowledge deficit related to cardiovascular medications as evidenced by unable to identify proper technique for radial pulse prior to med administration. And that would be a part of your teaching goal, and planning is to teach the goal, teach the objectives, or teach to the objectives, and help the patient understand why it's important to their healthcare. So let's look at this question. The client is given a pamphlet to read about how to manage their newly inserted central venous access device at home. It will be most important for the nurse to assess the client's A, health benefits, B, literacy level, C, fine motor abilities, or D, ability to see. Go ahead and take a couple seconds and make your selection. The correct answer is D. If the client has vision problems, the nurse will have to find another strategy to convey the information. So let's look at components of teaching. A teaching plan will have strategies like method used to present the information, the content, the information needed to reach your intended goal, scheduling and sequencing, have we heard that enough? How to organize and sequence information given, And then instructional material. So what are you going to give out? Is it a pamphlet? Is it a checklist? Are you going to format it differently, or a preferred language that you need to adhere to? So examples of teaching strategies: lecture, group discussion, demonstration, return demonstration, having the patient show you how to take their own blood glucose. One-to-one instruction, digital resources of information. Now, in a lot of hospital settings, they have the television in the rooms, and they have different videos they'll display for the patients depending on what that patient needs to learn. Printed materials, role modeling, online sources of information, and use of simulation technologies. One of the things that I encourage you guys to do is see what kind of printed materials your current facility has for their patients. Evaluation of learning, oral questions, interviews, questionnaires, checklists. So after you do the teaching, you go back and evaluate whether or not they're retaining that information. So one of the things that is very similar to what you go through is the first two, right? When we teach you in class, then we come back and we have questionnaires, aka assessments or exams for you to see if you're learning what we are teaching. And then direct observation or return demo, that's lab for you guys as nursing students. We teach you something, we show you something, and then we see you return demo that back to us to ensure that you are adequately following process. The same thing happens with your patients. You teach them and then you assess or evaluate their learning. And then client reports and client records. So a lot of times patients are sent home with a blood pressure cuff, a manual blood pressure cuff, and a documentation form where they will write their blood pressure every morning before they take their blood pressure medication and turn that into the physician when they go back to their appointment. And then tests and exercises. So we can come back and evaluate your learning. Maybe we are teaching you to eat better for your diabetic diet, take your insulin and adhere to that program, and take your blood glucose. And so in 3 months, we'll come back and do your A1C. Well, that's a test, and that's going to tell us how your blood sugar has been managed over time. And so that test will reveal whether or not you are indeed learning and behaving differently because of that education. So this is the last part of your extra credit. So I want you guys to imagine you have an adolescent girl recently diagnosed with type 1 diabetes mellitus, and you developed a teaching plan for insulin therapy and dietary management. While you are teaching, she is texting and not paying attention. What would be another way to teach her if she resists your approach? So tell me about that. And then what would happen if she failed to learn to manage her insulin and dietary management correctly? What are the consequences? And what other ways are there to look at this situation? So think about all the different ways you can handle this and tell me a little bit about what you would be thinking and your approach to this scenario. Thank you so much for attending this Learn session. Let me know if you guys have any questions, and happy studying.